All right. Welcome, everyone. And we still have a few people that need to roll in here. So before I do some housekeeping, you are in the correct place. If you're for neuro ophthalmic disease, I'm not even going to try to say the rest of it, the rules, the exceptions, and the exceptions to the exceptions to the rules, or however it goes. That's my creative partner there doing that. So while we're waiting, there's a polling question. If you guys that are here, if you go to the polling question, I'm going to launch a poll here just to kind of kill some time while people are waiting here. Here's a poll that I would like to just kind of see about the practice that you have. Is your practice not open yet due to COVID? Open for emergencies and urgencies? Are you open full time with reduced schedule, and you're pretty much back to normal? Kind of curious, and looks like people are using the poll function just well here. There'll be a couple polling questions throughout the webinar. This is part of the live and interactive, and COPE has been nice enough to allow us to do these live presentations, and most state associations are allowing you to get credit. So there we go with the polling question. So look at that. Looks like a few people still not open, and still open with a reduced schedule, and that's kind of where most people are, I guess, is what I've been seeing. So I'm going to end that poll, and we'll do one more here to kind of make sure everyone gets logged in, because I can see the numbers logging in. We're almost there. Reset that one. How about this one right here? Make this a little fun one. Will the NFL have fans at the football games? Ooh, look at that. Started off no right off the bat, and we got 15, 13%. Kind of what I thought too. There'd be a few people out there who cares. Now it looks like the majority have it as a no, Joe, and I'm going to guess the football season will occur with all the fantasy football and all the betting that goes on, but majority says no. There won't be any fans there.
Well, all right. It won't be for lack of trying, because they own an entire day of the week, so I'm sure they're still going to try.
That's true. That's very true. All right. It looks like most people are here, so let's get started, and I'll do some housekeeping. Joe, you have to let me know. I know you have a handout. Let me know when you want that to be launched. For people on the webinar here, you guys can see files. There will be it will go live, and then you can download the file. There's polling questions. As you see, we just did some polling questions, and Joe will have me launch a few here throughout the webinar. Again, it's part of the live and interactive. We're able to, by your IP address, tell when you log on, log off, and that's all the requirements that we need to really have for, along with some interactive throughout to be able to get the credit. This course is being recorded. Eventually, I will get it to our YouTube channel. We have Optometric Education Consultants has a YouTube channel. We have probably about 10 or 15 videos in there. We just started it this year. A few things about Quebec City, a few of our other webinars that we have, if you want to go back and reference them. With that being said, you will get a link in about 24 hours, about 14 hours from now. And it will have the link to this and a replay, but it doesn't last forever. So that's why we house them in the YouTube channel if you ever want to go back and rewatch them. Obviously, it won't be for credit. You've got the credit, but you can go back and rewatch and continue that learning. There will be a survey sent about 2 hours from now. The survey, we need that for the regulatory process. So please make sure you click on the link and fill out the survey. It will help us, but it's also part of the process that we need to have. The next thing I'd like to discuss is this is a cloud-based system. So we upload everything to the cloud and it's going out to you. So the best thing that you can do to have your best experience is decrease the competition at your house with the Wi-Fi bandwidth. We have Ring doorbells and refrigerators, and people stream and try and multitask while listening to a webinar, and it starts to cut out. Please, if you have someone, a child that's playing a game and using the bandwidth, just ask them to maybe stay off for a little bit, because it will help with the process. It's usually when people have problems from the cloud going to your computer. There is a reconnect button that will kind of ask you if you need to reconnect. That's only if you lose, and if you do, just hit reconnect. It'll put you right back in. We'll use the chat session here. I see people have already made a couple chats maybe, or maybe not. I thought I saw it lighting up. But the chat section will be for questions. You can post your questions there, and I'll monitor those while Dr. Salka is doing his lecture, and I can ask those to him, and you can get your answer to your question. And then the final housekeeping will be Vanessa, who is our conference administrator. She'll send your information to COPE, ARBO, whatever state licenses need that extra requirement, and you will get an email certificate from her in about a week. Now, she'll probably turn this around by the end of this week, but ARBO then is being swamped with all the webinars, so it's taking about a week, and it'll take you probably, Vanessa, to the end of this week to get you that certificate of attendance. So you'll get a certificate via the email that you used, and you'll also get it reported to ARBO if you turn in your OE tracker number. So before I introduce anything, did I miss anything, Joe?
No, I think that covers it pretty well. It's what we talk about every time we do one of these. I think you've covered it very nicely.
Okay, so let me introduce my partner, who I'm proud to be friends with and proud to share the optometric education consultants with. Joe has served as a professor of optometry at Nova Southern University College of Optometry, Nova, for 28 years. While here, Joe was the chief of advanced care service, the director of the glaucoma service, chair of the Department of Optometric Sciences. Joe also is a founder of the Optometric Glaucoma Society and the Optometric Retina Society. And tonight he's talking about Neuro Ophthalmic disease, and he is a chair of the Neuro Ophthalmic disorders for the Academy, so the American Academy of Optometry. I've written articles with Joe, and I found out that Joe is a gifted writer. Joe has hundreds, maybe thousands of articles out there in various publications. He is the lead author of the annual Handbook of Ocular Disease Management by Review of Optometry. Joe is a well-known national and international lecturer, and Joe this year has transitioned to, I think, Sarasota, Florida, or near there, and he's working for Center for Sight in Sarasota, Florida. So again, friend, colleague of ours, it's a pleasure to have Joe here talk about his discussions in neuro-ophthalmic disease. Joe, it's all yours. Thank you.
Thank you, Greg. That's a very nice introduction. I appreciate that. All right, let's switch over and look at our presentation. And Greg, does it look okay to you?
It does. You look good. So
all right,
I've got my camera off, and I'm going to go mute. So if you need me, it'll take me a second, but it looks great.
Okay, very good. Well, tonight's talk is discussion in neuro-ophthalmic disease. What I say is rules, exceptions to the rules, and exceptions to the rules. And this is going to be a talk all about rules, because if you follow some simple rules and a few straightforward principles, you're going to be able to manage a lot of patients with these conditions when they come into your office, and it's very important that you do so. I am or have been a consultant or on the speaker bureau or advisory board for a number of companies, including Novartis, Allergan, Glaukos, Bausch & Lomb, Aerie, as well as Ocular Therapeutics. I've got no financial interest in any product, and I am a co-owner with Greg of Optometric Education Consultants. Now, everybody has some sort of philosophy about neuro-ophthalmic disease. And I don't know if you remember this fellow, Thurston Howell III from Gilligan's Island. Thurston Howell III doesn't like neuro. For him, neuro equals referral or diagnose and adios. Now, that's actually the mantra of neuro-ophthalmology. Greg, you still there? See if Greg comes back.
I am here, Joe. Go right ahead.
Greg, do you remember? Do you remember Gilligan's Island?
I do remember Gilligan's Island. Yes, I do.
And do you agree it was a terrible show?
It was a terrible show.
Okay, I usually I'll do this with a live audience. I can interact with eye to eye, but I'm going to use you as my comic foil tonight. Do you know what the skipper's name was?
I do not. I don't know what the skipper's name is.
The skipper's name is Jonas Grumby. Do you know what the professor's name was?
I do not.
It was Roy Hinckley. And do you know what Mrs. Howell's name was?
I do not.
Her name was Wentworth Lavelle Howell. So anybody, when you fill out your survey, if you're asked, did you learn anything during this lecture, you can certainly say, yes, you did learn. You learned something. You learned the names of the characters. But managing patients with neuro-ophthalmic disease, we have to have a basic understanding of the anatomy, which we all learned in school, and we can certainly easily refresh ourselves. But it also involves following several fundamental principles and a few simple rules. If you follow these principles and rules, you're going to be able to manage a lot of patients that come into your practice. Now, it helps to have a network of referral physicians, including a neuroradiologist, hopefully, a neurologist. A good internist is worth his or her weight in gold, a neurosurgeon, and perhaps even a rheumatologist. Now, why is it important for optometrists to be involved in this? Well, I think it's important because we understand the visual system well. Neurologists don't understand the visual system as well as we do. There are a lot of testing that we can do. Pupils, color vision, OCT, perimetry, pupil testing. These are things that once a patient moves downstream, these tests don't get done. And it's very, very important. And there are not a lot of clinical neuro-ophthalmologists out there. I know the North American Neuro-Ophthalmology Society, NANOS, has about 400 members. And I think I recently saw that there are about 250 practicing clinical neuro-ophthalmologists across the U.S. So they need boots on the ground. And the former chair or president of NANOS is working with optometry. And he is trying to include optometry in neuro-ophthalmic disease because, as I said, they need boots on the ground. And there are patients who definitely need to see neuro-ophthalmologists and neurologists. But my philosophy, unlike Thurston Howell III, my philosophy is if you follow several simple principles and rules, you can manage 90% of the neuro-op patients that come into your office. And to do that, here's a personal case to prove my point. Now, as Greg said earlier, this is being taped, and you're going to get a tape, and it's going to end up on our OEC YouTube channel. So I'm going to proceed here at my own personal peril. And the reason is the personal case to prove my point. The patient involved is my mother-in-law, and I have permission to do this, more or less. And it's my mother-in-law. Now, let me tell you about my mother-in-law. My mother-in-law is a bit of a dramatic person. If there is that drama, it will be created, it will be nurtured, and it will be developed. Several years ago, my mother-in-law actually screwed up LASIK surgery. Now, how does a patient screw up LASIK surgery? There's only two things you need to do. Take a Valium and sit still. Now, this is before we had the complete laser procedure. We were actually using microkeratomes. Now, my mother-in-law believes that she is fundamentally different than other people. When I say fundamentally different, I mean like biochemically different. She believes anesthetic doesn't work on her as well as it does, a normal person. So while she's undergoing the procedure and they're making the cut with the microkeratome, she decided that the lid speculum that was holding her eyelids open was so distasteful, she intentionally, forcefully, successfully blepharospasmed it out while the microkeratome was making the cut, and it got caught partway across her cornea. So the surgeon had to inch it out, back it off, heal the cornea, and go back and do the procedure several weeks later, but it left her with some surface irregularities and a slightly reduced visual potential there. Okay, well, fast forward some time, and I'm going down to Australia to lecture. My wife's going to come with me. Oh, by the way, my wife is an optometrist as well. Very important part of the story. So my wife and I go down as a working vacation while I'm lecturing in Australia, and she makes arrangement for her mother to come over to house sit for us, watch her animals, which I was very happy about. And she made an appointment for her mother to go to our university clinic at the time and get an eye exam because she was having some visual difficulties. Well, we're in Australia, and she goes and gets an exam, and they can't correct her one eye, the involved eye, to 20/20. Now, there are a number of things that one can do. When you have an eye that doesn't see 20/20, you can do an OCT, you can do a visual field, check color, check pupils, and that's what they did. They actually did a visual field. Now, she did not offer the story that I just told you earlier in advance. So our colleagues didn't have the hindsight of knowing what had happened with the LASIK mishap. So we wake up one morning and we get an email from one of our colleagues who said, yes, she came in for an examination, couldn't have corrected her 20/20, and it appears as though she has a bitemporal defect. Now, when we hear bitemporal defects, we think chiasmal compression. Now, of course, my wife was sick with worry, but I'm reading between the lines, and I'm trying to explain to my wife, it doesn't seem, I'm not saying she has a brain tumor. It said it appears as though she has a bitemporal defect. So we can't communicate easily when we're across the date line. So finally, we get them to send the next day a copy of the visual fields, and this is what happened, what came back, and this is what we see. And we can see here that it is indeed temporal. It is bilateral. It does seemingly respect the vertical. But to me, this is not a typical bitemporal defect. And in fact, when I see bitemporal defects from chiasmal compression, if it's coming from below a pituitary, it starts about at the blind spot and moves up. If it's above from a cranial pharyngioma, it starts at the blind spot and moves down. Here we kind of have it on both sides. And while they're calling this a bitemporal defect, I am calling this an enlarged blind spot. So I know my mother-in-law was myopic at one point, so I asked my wife, do you know if she has unusual optic nerves? And she couldn't answer that question. She did not know. Now, my wife is sick with worry, and she is concerned that her mother has a brain tumor. And I'm trying to calm her down, and she's getting mad at me because she feels I'm not taking this seriously. Now, don't get me wrong. I love my mother-in-law. I don't want to see anything bad happen to her, for the most part. But I tried to explain to her I do believe that this is just a congenital anomaly. So we get back from Australia. I got my wife calmed down. We enjoyed the rest of the trip. She still was a little bit anxious. And she rushes her mother into the clinic and reproduces the field. And it was about the same thing. Now, it was my opportunity now to come and examine my mother-in-law. And this is what she has. And these are clearly not normal optic nerves. These are disc anomalies. Specifically, she has a manifestation of tilted disc syndrome. And this is what I expected before I even examined her while we're still in Australia. I am not worried. I am not concerned by this. Now, story gets a little more complicated. Her ex-son-in-law is an ophthalmologist, so she goes to him. He's a retinal specialist. He looks at her. He diagnoses optic atrophy. Well, we look at this, and these nerves aren't pale. The nerve is a center part in here and a center part in here. What's around it is this congenital coloboma and scleral crescent. That's scleral tissue there. That's not optic nerve. And I tried to explain it. He wants to do an MRI. Now, I don't mind doing an MRI, but my mother-in-law doesn't have very good insurance and a very, very high copay and deductible. And if anybody's going to be paying for this MRI, it's this guy sitting right here, which I don't mind doing if she needs it, but I know she doesn't need it. The visual field is not typical of chiasmal compression. So I get everybody to relax, stand down, code orange. And then something happened. I don't know what exactly it was. I think I might have gone to a conference. I lost focus. I let my guard down. She goes back to her ex-son-in-law, who now diagnoses a new onset relative afferent pupillary defect. Now, keep in mind, as a retinal specialist, he's not checking pupils. The technician is. So before you know it, she is getting an MRI. Before I even get back from the conference, she is on the MRI table, and it comes back perfectly normal. Well, we're still not quite done yet. Not quite there. So he sends her to a neuro-ophthalmologist on the university level who, during the exam, if you can believe my mother-in-law's recounting of the exam, and that's kind of a mighty big if, he checked her pupils, did a confrontation field, looked at the MRI scans, looked at her with a direct ophthalmoscope and said, "What are you doing here? You're normal. Get out of here. You're wasting everybody's time." This whole episode took about 4 months. For what I knew was going on when we were in Australia, just looking at the visual fields. Now, not quite out of the woods yet. I'm almost there, but my wife is still needling me. She keeps asking me, "Are you sure my mother doesn't have a brain tumor? Are you sure? Are you 100% sure?" And I said, yes. If you don't believe me, tilted disc syndrome can have a pseudo-bitemporal defect. And if you don't believe me, I pulled out just to show her, it's well known. It's in the peer review literature. I pulled out this manuscript that says, bitemporal visual field defects mimicking chiasmal compression in eyes with tilted disc syndrome. Don't just take my word for it. It's been published. So, very important. Anybody listening to this who knows my wife, do not tell her I told you this story. Because when she finds out, she's not very happy with me that I told this story. So, Greg, I'm hoping that this, somehow she doesn't trip across this on our YouTube channel or get a copy of this, because it's not going to end well for me.
Well, maybe I can do a little bit of editing there for you, Joe.
Thank you, Greg. So here's a rule. Congenital optic nerve anomalies can have sometimes dramatic visual field loss. And one of the biggest challenges I have, especially in glaucoma management, is when I'm trying to diagnose glaucoma and a funny-looking nerve that's congenitally anomalous, and we can't tell how much field loss was there to begin with. We just don't know. Here's a case that I helped out with one of my final cases at the university. A 41-year-old male who had blur at distance, correctable to 20/20 in each eye with a slight myopic correction. Had slightly constricted confrontation fields. Pupils were normal. Pressures were normal. But there's questionable disc pallor with small cups, and this one is why I was consulted. Now, he said he had an MRI years ago, but doesn't really know why, and thinks it might have been due to headache. And we take a look here, and what do we see? We kind of see an overall yellowish looking optic nerve. And I want to point out is the optic nerve is more or less right in here. Now, as I look, there's no obscuration of any vessels. I see no hemorrhages, no parapapillary folds, no juxtapapillary edema. This is pretty elevated right here. and we take a look at this on OCT, and there are some abnormalities on the OCT. There's a poor ganglion cell complex, especially in the right eye, some abnormalities. If we look, there's virtually no cup whatsoever in this. And we can actually see the superficial drusen, the internal lumpy, bumpy appearance. I'm going to go back here. I'm not sure exactly if I can completely see. The resolution's not great. But when you have nasal thickness on an OCT greater than 88 microns, that's more associated with disc edema than disc drusen, something to always remember. But here we got the internal lumpy bumpiness. There's no spread of subretinal fluid. I can even see a superficial drusen right there. But this is a visual field defect. And this was done at 30-2, and it was pretty significant. Now, do I have a reason for it to look like this? The answer is yes. Patient has disc drusen. However, if we take a look, it does have a very suspicious quadrant appearance to it. Now, fundus autofluorescence I didn't do. B-scan was very clear. Hyperrefractile spikes. MRI, do we do an MRI in a patient like this? The answer, in my opinion, is yes. Because it does have that quadrant type of appearance. There is a reason for it to be there. But just because a person has disc drusen or a disc anomaly does not mean they can't have something else going on. I was not expecting to find anything, and we didn't find anything. Now, can you treat drusen? Do you treat drusen? The answer is you don't. There is no literature support for using any medicine, especially bromonidine, in treating these patients. Now, there is some literature support if the intraocular pressure is elevated. We can use pressure reduction medicines to ward off against any potential glaucoma that may creep in and we not see it. But there is really no support about whether or not this is going to work. So we don't really treat optic nerve drusen. The literature just doesn't support it. Here's a rule: don't make diagnoses of immune disease in immunosuppressed patients. Patients who are on cancer therapy are not going to have autoimmune diseases. Now, this is what I call the audience participation part of this program, but I can't ask the audience very well. So Greg is going to be my foil again. Greg, are you there, or are you out having a mental pina colada? Greg? I think Greg is having his...
I am here. I had a double mute on just in case, because I was helping people get into the webinar. I think everyone's in. So no mental pina colada, but IT troubleshooting, which is all taken care of now.
Thank you, sir. All right. Well, Greg, I'm going to need your help on this, and we have not rehearsed this. Here's a question we're going to do, Greg. Give me any age you want of a patient.
57.
57, male or female?
Female.
With a previous history of cancer, presents with, give me any neuro ophthalmic finding you want.
A double vision.
Okay, very good. Patient also complains of, give me any symptom that you want.
Numbness.
Numbness, okay. Additionally, give me any finding you want, any medical finding you want.
Reduced acuity.
Okay, so a 57-year-old female patient with a previous history of cancer presents with double vision. The patient also complains of numbness. Additionally, I'm sorry, what was the last thing you said?
I forget already. Numbness? I don't know. Loss of vision.
Loss of vision. Okay. Greg, what's the most likely cause in this case? Is it cancer? Is it cancer? Is it cancer? Or is it all the above?
I'm going to go with C.
C,
Cancer.
are you sure? Or how about D, all the above?
I'll go with all the above.
Okay. That's very important. See, no matter what I do, the key here is previous history of cancer. Never diagnose idiopathic or ischemic anything in a patient with a history of cancer. Cancer is cancer until proven otherwise. Now, there's a big difference between a woman who was treated with mastectomy 25 years ago and a man treated for prostate cancer last year. A close friend of mine who's an optometrist contacted me. Her father had developed some double vision and looked like he had a sixth nerve palsy. Well, his history is also significant for a rare form of salivary gland cancer that had been treated probably 6 months before. And again, I told her, don't try to diagnose ischemic anything in a person with a history of cancer. And it turns out there was a metastatic lesion to the cavernous sinus. Greg, you still there? Interestingly, I had Greg did a great job on this, but interestingly,
I am here.
Hang in there, buddy. I was doing this in Australia one time with a mate of mine. This is the person who was president of Optometry Australia. He had a radio show. He had the gift of gab. So I put him on the spot, and he froze like a kangaroo in the headlights. I mean, it was painful. I almost ran out of time during the lecture. And when it came to he was hemming and hawing and stammering. I was shocked by it. And I come to the last part of the question. Additionally, I said, please give me anything you notice, any finding you notice. He goes, erectile dysfunction. You noticed that, did you? You never know what you're going to go get when you get to the audience. Greg, fill in the blank. This is an opinion. Acute painful blank is a neuro ophthalmic emergency. Give me your best guess, best answer.
Acute painful loss of vision.
Very good. Anything else? Is that your final answer?
Acute painful, I guess headache would be painful. Double vision. Yep, that's all. I'm going to go with loss of vision.
Okay, excellent. Well, acute painful anything is a neuro ophthalmic emergency. Acute painful headache, temporal arteritis. Acute painful headache, third nerve palsy. Acute painful dilated pupil, third nerve palsy. Acute painful small pupil, Horner syndrome. Acute painful double vision, third nerve palsy. So always remember, acute painful anything is an emergency. Now, if I can give you any rule to remember, and this is going to help you all out, how long do you have to work up a patient? The answer is, and of course there's always exceptions to rules, urgency of your evaluation is dictated by duration of a condition. Meaning, how long has it been there? That's how long you have to figure it out. Vision loss of 2 hours, you got 2 hours to figure it out. Double vision of a week, you've got a week to figure out. Vision loss of 6 months, you got 6 months to figure out. Something has been there for 10 years, you're normal. Go home, you bother me. There's nothing wrong with you. However long it's been there is how long you have to figure things out. Case in point, 46-year-old male reports waking up 3 months ago, not being able to see out of his right eye. Comes in, he's light perception, 20/20. He's got disc pallor, as you can see there, but no other concurrent findings and no known medical history. Now, my optometry resident, who's very good, she got nervous. She didn't call me. She didn't send text. She got nervous. We weren't in the same building at the same time, so she sends to the emergency room immediately. Question is, how long do we have to get this worked up? The answer is 3 months. It's been there for 3 months. He's had no change in 3 months. It's been there for 3 months. It's not an emergency. You've got 3 months to figure this out. Rules must be obeyed. 57-year-old female is a low-risk ocular hypertensive in both eyes. Comes in, OCT, optic nerve, everything is perfectly normal. And that's what she looks like. And what we see is a large cup to disc ratio, which is why she is referred to me for an evaluation. But the rim tissue is pink. It is perfused. There's no notching of the neuroretinal rim. The OCT looks fine. Everything is within normal limits. And this is one situation where I saw the patient once, got a dilation, funded his photos and a pressure check, brought the patient back for an OCT. OCT is fine. Pachymetry is average. At this point, I'm thinking to myself, well, we're done. It's an ocular hypertension. We will watch. I thought, come back, one more pressure check for visual field. Let's just be complete with our database. And the fields actually surprised me. And that's what the field looks like. And one has to ask, where is the lesion? Greg, you still there?
I'm here.
What are your thoughts here on this lesion?
Am I allowed to see the other eye yet?
Why do you want to see the other eye?
Well, if the other eye is involved, then I can tell whether it's, monocular, like in front of the chiasm to the optic nerve, or chiasm and beyond. So.
And that is absolutely correct. I mean, we certainly think that this is neurologic because it respects the vertical, and these are all less than zeros. So when it is respecting the vertical, we're thinking chiasm or behind, and for that reason, you want to have the other eye because we need to localize where it is, because chiasmal and retrochiasmal disease will virtually always have bilateral findings. This was her other eye. So the question becomes, where's the lesion now? And Greg, I think you point out very well, involvement in one eye should be anterior to the chiasm.
Should be.
The only problem is this person has nothing else wrong with them. Pupil is fine, vision is fine. We saw the optic nerve, we saw the OCT, we saw the nerve fiber layer. There's no dyschromatopsia. There's no dysfunction that goes along with this. So can this actually exist? The answer is it shouldn't exist. What do we do next? What test do we order? We simply repeat the visual field. What happens when we repeat the visual field? It looks like that. And how did this come about and how did this happen? Well, I worked at the university when I saw this patient. We work with students. Students are the perimetrists, and they're not always the most well-trained perimetrists. And when she set this test up for a first-time test taker, did not say to the patient, we're going to start by testing your right eye. She said, we're going to start by testing your right side. The patient was under the impression she should ignore everything on the left, which is what she did.
She did a pretty good job of it.
She did a darn good job, and if she had done that in both eyes, we can only imagine how much unnecessary testing she would have gotten that day. So a rule is chiasmal and retrochiasmal lesions will have bilateral involvement virtually every time. But unilateral, as you point out, Greg, visual field loss represents anterior visual pathway disease, which should show something identifiable in the form of damage to the vision, the color vision, the disc, the nerve fiber layer, and the pupillary pathway. Here's a rule. A patient can fake a field, but can't fake a retinal nerve fiber layer or pupil defect.
Hey, Joe, we had a few questions roll in here if you want to take them now.
If you read them to me, please.
Yep. Going back to this person, the very first person that we're not supposed to be letting Lori know about, yes. They were just asking what it was her RX. And I'm not sure if she had cataract surgery, and if she did, maybe before and after. Or she had LASIK, so before and after.
That's a good question. She had LASIK. And the best of my recollection, I think she was in the 8 to 10 range.
So that kind of explains a little bit of those findings. Okay.
Absolutely. Yep.
Suzanne has made a comment about the filling in the blanks. We have Mad Libs optometry style, and only us that are of probably a few gray hairs probably get that. Maybe the younger audience doesn't get that, but the Mad Libs optometry style, I like it. We have a comment. Netflix has good Australia-based shows. And then we have a question here that says, did you say that a patient with cancer cannot have autoimmune disease?
No, what I'm saying is we should not be looking for autoimmune disease in patients who are immunosuppressed, such as on cancer therapy or anti-rejection drug therapy.
Thank you. And then the last one here to get us caught up is we have a comment or a question that says acute, not or none painful diplopia. So acute, non-painful diplopia, emergency?
Not necessarily. It could be, but not necessarily. But what I'm trying to emphasize is if something is acute and painful and it's neuro-ophthalmic, we have to treat it urgently. Good question.
Perfect. Okay, so that gets us caught up.
But when it's painless, it's not necessarily a killer. Always remember. Okay, 59-year-old male came into the general service at our eye institute for a routine exam one year. Cup to disc ratio is 5/5 in each eye. Pressure is 20. Patient was given a prescription for glasses and released. Comes back 2 years later complaining of a slowly progressive loss of vision in the right eye. He now has a relative afferent defect in the right eye, 20/80 vision, 20/20 left eye, a superior altitudinal defect splitting fixation in the right eye, and a mild inferior defect in the left eye. And the patient is said they have disc pallor. Now, I had not seen the patient at this point, but the patient was told, you have what's called a non-arteritic anterior ischemic optic neuropathy. You've had a stroke in your eye. There's nothing we can do for it. There's no treatment. Now, what's wrong with this picture? And if I left people to ponder it, I think we'd all come to the conclusion there's about 4 things wrong here. Now, what's wrong here? Okay. Slowly progressive loss of vision. Ischemic neuropathies are relatively rapidly progressing. There's a superior altitudinal defect. Well, 6-1, it's most likely with an ischemic neuropathy going to be an inferior defect. There's also defects in the other eye. Ischemic neuropathies don't affect the fellow eye. But what troubles me most was a cup to disc ratio of 0.5/0.5. I think we all recognize from school and from our training and residencies and experience that non-arteritic anterior ischemic optic neuropathy happens in patients who have a disc at risk. The small, chubby, crowded, non-existing cup where everything is crowded in there, making them prone to infarction. So there's just too much wrong with this picture. I saw the patient, the pressure is 23. Now, this is not the same patient. This is just a representation. It is a very, very shallow cup and about 95% cupped. It was glaucoma. Patient had their optic nerve misassessed. Their glaucoma was not treated, and over 2 years lost their fixation in the right eye. But this is not the patient. This is just an example. You can't look in this area here. You have to look where the vessel bends. Here's an important rule. Do not make the diagnosis of non-arteritic anterior ischemic optic neuropathy in glaucoma patients. It doesn't happen. Glaucoma is a disease of cupping. Non-arteritic anterior ischemic neuropathy is a disease of non-cupping. 97% of non-arteritic anterior ischemic optic neuropathy patients have a 0.2 or less CD ratio, and the other 3% have been misdiagnosed. Here's a rule. Diagnoses of exclusion should be your last diagnosis, not your first. Here are some diagnoses of exclusion or common diagnoses that we use, terms that we use that probably are being used inappropriately. 80s tonic pupil. That's a light near dissociated pupil in an otherwise healthy young adult, often female, often with loss of deep tendon reflexes. And when we see when a tonic pupil is seen, people say 80s tonic pupil. Understand other things can cause a tonic pupil: diabetes, trauma, zoster, and giant cell arteritis. Pseudotumor cerebri is often a diagnosis that is reached prematurely without doing the appropriate testing. Always understand that females who are of childbearing age and who may be slightly over their ideal weight can still have brain tumors. Bell's palsy, facial nerve paralyses are also caused by certain irritative lesions as well as zoster. I just mentioned non-arteritic ischemic neuropathy. It's a clinical diagnosis, but there's no test for it. Tolosa-Hunt syndrome. 100 years ago, a guy named Tolosa and a guy named Hunt saw some patients with painful ophthalmoplegia. Their skull x-rays, which is all that they had at that time, were normal. So now we have Tolosa-Hunt syndrome. The last case of presumed Tolosa-Hunt syndrome that I was involved in actually was neurosarcoid. Very treatable disease. So making these diagnoses of exclusion your first diagnosis instead of your last is going to put the patient at risk. Nice case I got from a colleague of mine, 48-year-old white male, wakes up one morning, notices something is wonky with his vision. He still sees 20/20, but his visual field is just isn't right. He had the flu a couple weeks ago, which turned out to be a red herring. And he had a new onset inferior arcuate defect. And what I point out is it's not an altitudinal defect. These are typically glaucoma-like arcuate defects. When we take a look, he's got a hyperemic swollen optic nerve, juxtapapillary hemorrhages. In the other eye, this is actually glial tissue. He had a small, non-existent cup. He had a disc at risk in the right eye and a true non-arteritic anterior ischemic optic neuropathy in the left eye. A clinical diagnosis when everything fits. Now, here's a very important rule. Pallor in excess of cupping indicates something other than or in addition to glaucoma. And I'm not talking about the 95% cupped nerve where you're looking at scleral tissue, glial tissue, and there's just so little rim left you can't really assess. I'm talking the 60 and 70% cup where you can actually see disc pallor. So pallor in excessive cupping is something other than or in addition to glaucoma. That's rule number one. But rule number two is nothing notches a nerve like glaucoma. Tumors don't notch nerves. Trauma doesn't notch nerves. Demyelinating disease doesn't do it. Infectious disease, nothing notches a nerve like glaucoma. If the rim is pink and the rim is notched, you're looking at glaucoma. If the nerve is cupped and the rim is pale, you're looking at something else. If the rim is notched and the rim is also pale, you're looking at glaucoma and something else. Now, we always ask in the age of imaging, do we still need to do visual fields? Nobody likes doing visual fields. Patients don't like it. We don't like it. It's tedious. Here is a 54-year-old man from Nigeria who got referred to me for glaucoma management. He had been diagnosed with glaucoma 6 years earlier in Africa, but underwent no treatment. I don't know why. He came to our general care clinic at the university. He had 20/30 in the right eye and hand motion in the left eye. He was told, you have vision loss from glaucoma. It's not coming back. We need to protect your right eye. Very reasonable. His pressure was elevated at 30 and 23. He was put on a prostaglandin, referred over to me in the glaucoma service with now a pressure of 17 and 15. And this is what he looks like. And this is why I love photographs. I love the camera. The camera is our friend. Take pictures and look at them. The patient has about a 70 to 80% cup to disc ratio in each eye. But when comparing the left eye to the right, we can see there is a distinct neuroretinal rim pallor. The pallor is greater than the cupping. See, when we talk about 95% cup nerves, the pallor and cupping is probably the same. Here, it's in excess. And at a 0.7 or 0.8 from glaucoma, this is not hand motion vision. Not acceptable. They had done a GDX, OCT would have shown the same thing. Roughly a normal nerve fiber layer in the right eye and a moderately abnormal nerve fiber layer in the left eye. It was felt because of his lack of English proficiency, he would not be a very good field taker. But do we really need to do fields in a case like this? The answer is yes, because when I reviewed the case prior to seeing the patient with my students and residents, I said there's something else going on here. The question is, how easily are we going to figure it out? The answer is relatively simple. Visual field, he's got a bitemporal defect. He had a large pituitary macroadenoma, an anteriorly fixed chiasm. He was actually compressing the chiasm as well as the left optic nerve, which explains his vision loss. But what I want to point out is his nerve fiber layer in the right eye was essentially normal, yet his visual field isn't. So if you're ever wondering, yes, we still need new fields in the age of imaging because sometimes it's not glaucoma. Now, sometimes glaucoma gets complicated. 70-year-old male, who's a patient of mine for several years. He has glaucoma. There's no question about it. He developed an auto accident with a concussion. He gets into an auto accident with a concussion, loss of consciousness. Afterwards, he developed what is known as gaze-induced amaurosis fugax. Now, when I say that, what do I mean and what am I implying? Well, gaze-induced amaurosis fugax, it's an old term, but it means when a person looks in a certain direction of gaze, their vision blacks out. And that is highly suggestive of a retroorbital mass. That when somebody looks in a direction, say they look to the right, there's an excursion of the optic nerve, touches something that shouldn't be there, the cessation of blood flow, cessation of axoplasmic flow, shuts down, patient loses their vision temporarily. They look in another direction, the optic nerve skirts back, reperfuses, now the vision comes back. The patient's primary care physician heard this, sent him to a neuro-ophthalmologist who thought the same thing, did a complete evaluation, MRI came back as negative. No mass. So the neuro-ophthalmologist said that in all likelihood this is a psychological or hysterical vision loss, and the patient was not appreciative of that. He didn't like being called crazy, and that is a very dangerous term for us to use because it's very hard for us to diagnose this. Now we take a look, and what do we see here? Okay, these are his optic nerves. They're small. He is notched inferiorly. He is notched superiorly. He is notched inferiorly there. So he is notched. We look at his neuroretinal rim. His neuroretinal rim is pink and perfused. It is well formed in there, and he looks pretty solid. So I told you, pale and excessive cupping is something other than glaucoma, but nothing notches nerve like glaucoma. He is not pale, and he is notched. We're only looking, in my opinion, at glaucoma. So let's go back to his history. Now, the interesting thing with neurologists and neuro-ophthalmologists is they're very skilled history takers. They will spend a great deal of time verbally dissecting out what's wrong. Most good neurologists and neuro-ophthalmologists know by the end of the history what is most likely wrong with the patient. And what they'll do is they will order the appropriate test to support or refute their hypotheses. If something comes back as being positive, the patient is referred to the proper medical specialist. Nothing comes back, then they're going to bring the patient back in 6 months, and if everything is stable, they're going to release them. Now, we as optometrists are like philosophers searching for truth. We feel that if we test and test and test and test and work long enough, we will absolutely find an answer. And in neuro-ophthalmic disease, that's not true. We have to know when to quit. So going back to the history is, I ask him, is this still happening? If he tells me no, problem solved. We don't worry about it. If he tells me yes. It happens every day. Questions I'm going to ask. Is it one eye or both? Can't tell me. Does it happen? Is it still happening? Yes. How often does it happen? It happens every day. Is there anything that you do that precipitates? And he said yes. He told me that whenever he shaved, he lost his vision. So I asked him if he could demonstrate it to me. So he got out of my chair. He walked over to my mirror, pulled the mirror down. I don't think we ever used that room again. We never got the mirror straight. And as he started to demonstrate, he turned his head up and he mimicked using a razor. He said, right there, he said, I just lost my vision. Now, no, he's not compressing his carotid artery because he's got a razor in his hand. If he's compressing his carotid artery, he'd be cutting his own throat. It's actually simpler than that. We see he's not pale. We see he's not. He's got glaucoma. There's his visual field. And when he turned his head to shave, His nose blocked part of the visual field that compensated, and he just became more aware of his loss. Sometimes it is glaucoma. So with that, I want to leave you with what I call my ode to a cup disc. Oh, to have a cup disc pink, that, my friend, hath a glaucoma to stink. But to have a cup disc pale, call this glaucoma and you shall fail. Disc and field damage is one-sided, simply cannot be abided. It might be trauma, infarct, or meningioma, but if the rim is cut, always remember, nothing notches a nerve like glaucoma. And if you can remember that, this is going to keep you out of trouble with a lot of optic nerve in your practice. Greg, I think it might be time for polling question number 1. And you have to read it to me because I can't see it from here.
Okay, let me get it published here and get it launched. It says here, which condition is least likely to be found in a patient with glaucoma? Retinal vein occlusion, macular degeneration, non-arteritic ischemic optic neuropathy, and compressive optic neuropathy. People are weighing in. Are you able to see the results, Joe?
No, I'm not gonna kick out of my screen share. So I'm gonna let you do that and tell me how we end up.
Okay. People are still rolling in. So, which condition is least likely to be found in a patient with glaucoma? Retinal vein occlusion is not winning. Macular degeneration is second to last. Compressive optic neuropathy and non-arteritic ischemic optic is at 71%.
Very good. That's what it should be. They're almost mutually exclusive. I've unfortunately seen colleagues, optometric and ophthalmologic, use that catch-all phrase, non-arteritic anterior ischemic optic neuropathy, when they see disc pallor, in an effort to avoid an evaluation. Non-arteritic ischemic neuropathy is a great diagnosis of convenience. There's no test that conclusively proves it, and even if there was, there's no treatment for it. So it's a nice catch-all. But remember, you have to have that disc at risk. So very good. All right, Greg, unless there are any questions, I'm going to move on. Case history. A 46-year-old male who complains of a droopy left eye began 6 weeks earlier. He had headache and numbness on the same side, and he had quote-unquote hives, which I didn't see at the time. He went to an ER, and he was diagnosed with a STI and given a non-effective antibiotic, and was referred to me by a local optometrist who just happened to run into him in a social situation. They got to talking and said, hey, go see my friend Joe, see what he has to say. Medical history is ocular history is unremarkable. Medical history had mitral valve prolapse, reflux disease, and what troubled me was a weight loss of about 20 pounds over 6 months, which was not intentional. I'm not going to go through all the details here. Suffice it to say he had a left upper lid ptosis, a left meiosis, and he looked like this. I think that when we talk about ptosis and meiosis, I don't get into anhidrosis myself, but it leads us to a pretty firm diagnosis, and that is Horner syndrome. So I strongly suspect he has Horner syndrome, but I have not yet diagnosed him with this. What do you mean by that? Well, I want a little bit more proof, and there are some things we can do to prove it. And we've always used some pharmacologic testing. And historically, we used to use cocaine testing, followed by hydroxyamphetamine testing, trying to localize it. I'm going to tell you right now, it's not practical, but we do have something that is somewhat practical, and that is the use of iopidine or aproclonidine. And this is what happened 30 minutes after putting iopidine in the eye. We can see his pupil is dilated, his lid has elevated, and it looks now like he has a right Horner syndrome. That's what we call reversal. So here he is pre-iopidine and here he is post-iopidine, and our diagnosis is pretty well confirmed that he has a Horner syndrome. Now, if you don't have access to iopidine, I always have at least an expired bottle in the office for just this reason. You can do what is called a dilation lag. If you put a normal person into a dark room, both pupils are going to dilate. A person with Horner syndrome doesn't dilate quickly, but it will dilate. And there is a reduction of the anisocoria after about 5 minutes in a dark room. Now, the challenge is measuring pupils in a dark room, but that's something that is always readily available, and it's very, very accurate. Now, I know he's got Horner syndrome, but I don't know why he has Horner syndrome. Headache, neuralgia, and hives. Cluster migraine can cause Horner syndrome, but this doesn't sound like a cluster migraine. Zoster can cause a Horner syndrome, but his hives didn't sound like Zoster to me. His weight loss was a little concerning. We didn't have an explanation, so the relationship's unclear. So my approach is, let's get a physical with a primary care physician and look at the weight loss, and based upon what he or she finds, then I can go about better trying to find this. Now, how long do I have to figure this out? How long has he had it? He's had it for 6 weeks. Got 6 weeks to figure it out. So what is Horner syndrome? It is a triad, and be very careful with the word syndrome and biad, triad, quadrad. It isn't necessary to have every aspect to make the diagnosis. I've come across Horner syndrome that only had one finding, but it is generally a triad of clinical signs arising from disruption of the sympathetic innervation to the eye and face that causes miosis, ptosis, and anhidrosis. So we start here in the dorsal hypothalamus, goes down the spinal cord to T1 where it synapses, goes up over the apex of the lung where neuron number 2 synapses to the superior cervical ganglion. Now it goes from the superior cervical ganglion, the sweat glands of the face, to the pupil, and to the muscle of Mueller. So 1, 2, 3 neuron arc. And this is like travel. This is like air travel. The more connections you have to make, the more likely your travel is going to be disrupted. Now, we have all learned in second grade of optometry school that when we have lesions from the superior cervical ganglion on forward, they're benign. And when we have things that are preganglionic, they're more serious. This is not true. Bad things happen everywhere. Now, pharmacologic testing, cocaine testing was done, hydroxyamphetamine was used. They're not readily available. And trying to localize it with hydroxyamphetamine is just not necessary because bad stuff happens everywhere. Now, iopidine, apriclonidine. This works on the process of denervation suprasensitivity. And what do I mean by that is those neurons, those postganglion neurons, are so starved for norepinephrine they become supersensitive. So even weak, you see, iopidine, apriclonidine, is an alpha-2 adrenergic agonist that has weak alpha-1 properties. Okay, alphagen, no, doesn't work. Phenylephrine, no, doesn't work. Iopidine works. It has weak alpha-1 receptor properties. So even with a weak alpha-1, it will cause the pupil to dilate and the lid to elevate. And it will actually even cause a reversal. That's even more classic than cocaine. Now, the caveat is it doesn't happen right away. It takes 36 to 72 hours for this supersensitivity to set in, and you can have a false negative. However, the dilation lag should be there present. Greg, I heard you in the background. Do you have a question, or does somebody have a question?
Yes, and it's a great question here, and it's very good timing is when you're using the iopidine, are you putting it in the eye that's miotic, or are you putting it in both eyes?
I am just putting it in the suspect corner eye, because I want to use the other one as a control, because I don't want any sort of possible dilation or even weak dilation. I'm only putting it in the involved eye. That's a great question.
And then we have another comment that just rolled in that says hydroxyamphetamine cocaine sounds like Breaking Bad.
Yes, it is, and in fact, I've had to use it before. During my residency, the liquid cocaine was kept under lock and key. You had to weigh it when you took it out. You had to weigh it when you went back, and you hope to God you didn't spill anything or drop it or lose it, because you're pretty much going to jail. Yeah, it is. It's like Breaking Bad. Horner syndrome, Breaking Bad. Now, what's going on? From the brainstem down, you got stroke. Younger people, think multiple sclerosis. Second order tumor, particularly lung cancer, metastatic disease, thyroid adenoma. Patients who have pain in the arm or the scapular region or weakness in the hand should be considered having a Pancoast tumor. And always consider, unless it's congenital in kids, Horner syndrome is generally pretty bad. Now, third order, the ones we were told are supposed to be benign, we've got headache syndrome such as cluster migraine, Rader's paratrigeminal syndrome, internal carotid dissection, which I'll talk again, herpes zoster, earaches, Tolosa Hunt, there are those guys again. How do we manage this? The best thing is to have an idea of what you're looking for and do a targeted workup. If they have neck and facial pain, we got to consider carotid dissection. Facial paresthesias, we have to look into the middle cranial fossa. If you don't know where to look, these are labor-intensive patients. They actually need 3 scans. They have to be scanned from chest to head. And these are 3 different scans. They need an MRI of the brain orbits and chiasm with and without contrast, with attention to the middle cranial fossa. They need an MRA of the head and neck to rule out a carotid dissection. They need an MRI of the neck and C-spine that includes the long apex and the brachial plexus. These are 3 different things. Image head to chest, 3 images. Now, if you can't remember all of this, and sometimes it is not easy to remember, understand that most radiologic centers have a Horner's protocol. If you explain to them what you're looking for, they'll know what to order. Now, in this patient, he came back after about 5 weeks and had not gone to a primary care physician. He had not lost any more weight, but had not seen his PCP. So 5 weeks are gone. I've only had my mind got 1 more week to figure this out. So I write him a note for 3 images. He doesn't go. He doesn't get this checked out. But he does get nervous, and he goes to an emergency room and starts talking to the triage nurse. And I'm not sure what was said, but he was admitted for about 3 days, and he got all the scans that he needed, and everything came out as unremarkable. They found nothing. Now, I have a suspicion I know what it is in retrospect, and I believe he had a carotid dissection. And let's talk about this. This is the part that's very important. This is the 3rd order Horner syndrome that has some sort of pain. Head pain, eye pain, neck pain, face pain. It's acute. It's often traumatic, but may happen spontaneously. And what happens is, keep in mind that the oculosympathetic plexus in the neck region coats and travels with the carotid artery. So something happening to the carotid artery is going to affect the oculosympathetic plexus. Carotid dissection is a linear tear in the wall of that vessel. And what that allows is thrombosis. and with thrombosis can cause emboli. And the emboli can move further up the vascular tree and cause a cerebral vascular accident. This is actually an emergency. This is a neuro ophthalmic emergency. A new onset painful Horner syndrome, spontaneous or especially traumatic, auto accident, whiplash, chiropractic manipulation. These are all things that indicate a carotid dissection and is an emergency. So this is a sudden or gradual onset of pain, hemicranial pain, headache, eye pain, face pain. The reason that this is so serious is 52% of patients will have a hemispheric stroke within 6 days. 2/3 will have a hemispheric stroke within a week. Nearly 90% within 2 weeks. After 31 days, there's virtually no risk. These are patients that can do well. They can be anticoagulated. They can be heparinized. It's not neurosurgery. The vessel wall will repair itself. Okay, it will repair itself. They will do well if they get the proper supportive therapy. So Horner syndrome suspected carotid dissection should go directly to the emergency room. And if you've done the iopidine test, please tell them what side and what's going on so they don't start concentrating on the wrong side. So my algorithm for Horner syndrome is just this. Confirm it is Horner's with aproclonidine or a dilation lag in a dark room. Is it accidental or surgical? And get the urgent imaging. CT, CTA, MR, MRA of the head, neck, and the chest if less than 2 weeks in duration, and image the lung apex. Now, I was talking or doing a program with a neuro-ophthalmologist, Steve Hamilton, out of the Pacific Northwest. He said, out of all these, the most important is the MRA. That's the most important thing we can get. So diagnosing Horner syndrome is not sufficient. You have to try to ascertain a cause and never ever assume that it's benign. Compare and contrast this to one of my long-term glaucoma patients. She comes to me for a glaucoma. Now, she's a glaucoma patient, but she's not a good glaucoma patient. Her visit rate is usually like once every 18 months. Not one to use medicines very well. But she comes in for a glaucoma follow-up, complaining of a drooping right eye and a smaller pupil for about a month, which she noticed at about the time of diagnosis of lung cancer and surgery of a lobectomy. Also complains of scapular pain and weakness in her right hand and comes to me and is asking, is this due to my lung cancer? My doctor tells me no. I tell her yes. Now, medical history, lung cancer recently diagnosed and surgically treated, pancreatitis, hypertension, acid reflux, just like the other patient. So maybe acid reflux is a risk factor for Horner syndrome. I don't know. I'm just kind of making that up. Interesting social history, smokes a pack a day for 45 years, drinks a 6-pack of beer daily, and that's the conservative estimate. She tells me sometimes she drinks a 6-pack, sometimes she drinks a case. And she looks like this, and she has a new onset ptosis, she has a new onset meiosis, and she has a new onset diagnosis of lung cancer. So we're doing the same thing, but we're working backwards. I didn't do any pharmacologic testing. I've seen her before. I know what we're looking at, and she had Pancoast syndrome. This is a tumor, a lung cancer arrives in the apex of the lung, involving structures of the apical chest wall. They're often going to have the shoulder weakness, hand weakness, shoulder pain, scapular pain. Treatment can be chemotherapy, radiation, surgery. And I think we all learned when we heard about this, when we were learning this first day in optometry school, gosh, we might be diagnosing lung cancer by doing an eye exam, and this is probably the worst thing that's ever going to happen. And it's not an emergency. The prognosis is actually very grim. The 5-year survival of Pancoast is around 30%. Yes, they need medical care, but I'm not going to call this, quote-unquote, life-saving. Carotid dissection, that's life-saving. Now, my girl Shirley, like many people that we know, people who have life-threatening diseases, they will change their diet, they'll change their habits, they'll try new therapies, they'll get in clinical trials. Shirley said, I'm going to beat this. I am bound and determined. I am going to beat this. Yet she didn't change her social habits, so I certainly doubt it. That was the last visit I had with her, and I strongly suspect she's no longer with us. Greg, I think it might be time for polling question number 2.
Okay, let me get it up here. This was the first one. And we're going to start it. What is the most likely etiology of a patient with a new onset painful Horner's syndrome? Lung cancer, brain tumor, carotid dissection, migraine headache. For those out there looking for where the polling question is, I believe there's a polling button on your side. My view is a little bit different. You click on that and the polling question should be there, and you should be able to click on your answer. So again, what is the most likely etiology of a patient with a new onset painful Horner's syndrome? All right, Joe, we have 1% that has said brain tumor.
Always possible.
Migraine headache, 5%. Lung cancer, 6%. And carotid dissection is winning by many furloughs at 87%.
And very good. That's what we always have to consider. The new onset painful Horner's syndrome, we have to consider first and foremost carotid dissection. That's a lot to remember. I did give you a lot of information, so if you can't remember that, I want you to remember my ode to Horner's syndrome. When the lid is low and the pupil small, check to see that the sweat don't fall. Cocaine is no longer universal. Iopidine will cause reversal. You have to scan head to chest, and remember, MRA is best. Pain and association will surely cause commotion. Send to the ER without correction. Remember, it might be carotid dissection. And if you can remember that, that's all that you need to know for Horner's. Greg, are there any questions or comments we should address now?
Let's see. No, nothing has rolled in. Everything's good.
All right. Well, here's another rule. Suspect the worst. He's a 63-year-old Indian male who's a long-standing glaucoma patient of mine. You know, interestingly, I realize most of my stories begin the same way. You know, a priest walks into a bar. Okay, well, a glaucoma patient walks into my clinic because they're all glaucoma patients. He had a sudden onset of orbital pain and retroorbital pain and headache for 3 days duration. It began on a Friday, got worse on a Saturday, was terrible on Sunday, and he comes to see me on Monday, even though we have emergency services, but I'm his eye doctor. He's diabetic and hypertensive on Coumadin with a pacemaker, kind of important part of the story. No vision change, but comes in Monday afternoon as a walk-in emergency glaucoma evaluation, and he looks like this. And I will tell you, known him for many years, he has never looked like this before. This is all brand new. And what we can see is a partial ptosis, and the eye looks a bit down and out. So when we raise up his lid, he cannot look up, cannot look down, cannot adduct the eye and look left, but he can easily abduct the eye. So he has limitation of elevation, depression, adduction. Abduction is fine, and he's got a partial ptosis. So the next thing we have to look at or we have to assess are his pupils, and maybe it's a little hard to see. He is 2 millimeters in responsive, brisk in the left eye. He's about 5 millimeters unresponsive, no reaction to light at all. And I think that we can probably all assess the patient has a third nerve palsy, or I can be more specific, he's got a partial third nerve palsy, and even more specific, a third nerve palsy with pupil involvement, or partial third nerve palsy with pupil involvement. Near complete, but not quite all there. So a pupil-involved third nerve palsy of 3 days duration at least. Most likely cause is an intracranial aneurysm. That's what we have to consider in these patients. Now, what did I do with this patient? This exam was simple. It was fast. The exam was about 10 minutes. I looked at him. I checked the pupils, checked the vision. I took the photographs, and I spent the rest of the time talking to him and his wife. I explained you need to go to the emergency room. This is the most important thing that you can do. I wrote a note to take with him. The note said, right third nerve pupil involved third nerve palsy, suspect posterior communicating artery aneurysm, patient needs to see neurosurgery stat. Now, I offered to call an ambulance. The patient and his wife declined. She said that she would take him immediately. I believed her. But you're not wrong to call an ambulance. There's an aneurysm that's ready to pop. If it happens, it's better to happen in an ambulance than in a cab or a spouse's car. And as I was explaining it to him, his wife asked me, and I could see that she was becoming somewhat anxious. And she said, how much is this all going to cost? We don't have insurance. My response was, it doesn't matter. He's going to die. You don't walk this off. It doesn't get better. He will go home. He will lay down. He will become comatose, and it will be too late. I'm happy to say that within 45 minutes of saying that, I got a call on my cell phone. He was already in the CT scanner. He was hospitalized, admitted and hospitalized for 23 days, treated with endovascular packing of coils into the aneurysm twice, and he survived. And this is what he looks like right now. He has what is called secondary aberrant regeneration. This is expected after an aneurysmal third. What happens is when the third nerve starts to regenerate, it does so aberrantly. Fibers that are supposed to go to the inferior rectus go to the levator. Fibers going to the medial rectus go to the levator. And when the patient looks medially, the eyelid goes up. They look laterally, the eyelid comes down, or what we see here is called pseudo-von Graefe sign. When he looks down, inferior rectus and levator are working together. I will tell you right now, his ptosis almost completely resolved, but his motility never improved. If this man walked into your office and did not tell you his history, most people would panic. He's got a slight ptosis, all the markings of a third nerve palsy with a fixed dilated pupil. He needs to say he has been adequately treated neurosurgically. So the clinical picture is an eye that is down and out with a ptosis. There is an adduction elevation depression deficit, so the patients may be isochoric or anesochoric. Here's an example of a patient that I saw on follow-up. I did not see him initially. And this is something that ended well that could have gone badly. He's a very older man who had a third nerve palsy. Yes, there is ptosis there. It's kind of hard to tell with all the dermatochalasis. When he had come into our primary care clinic initially, he had a partial third nerve palsy. Partial third nerve palsies can sometimes be more ominous than complete third nerve palsy, and I'll explain why. His pupils were reactive. There was no pupillary involvement. MRI imaging was obtained through the patient's primary care physician. Now, when I saw the patient in follow-up, a week later, he had a complete third nerve palsy. And the rumor going through our clinic was a third nerve palsy went bad. No, it didn't go bad. It just progressed. Going bad means when the patient goes dead. Now, I actually looked at the MRI report, and I can say I shuddered a little bit that everybody got lucky, including the patient, because this was done through the primary care physician. Now, this patient was diabetic. He had a blood sugar in excess of 300 and a hemoglobin around 11 or 12. Horrible, horrible diabetes. And I'm sure the clinician who spoke to the primary care physician was overwhelming the PCP with all the talk about aneurysms and all the possible causes, but probably said, but because of the patient's diabetes, it's most likely ischemic. Bing, that's the word the PCP heard, ischemia. So when the MRI was ordered, it was ordered not for intracranial aneurysm, it was ordered for brain ischemia. Remember, the best neuroradiologists in the world cannot help you if you don't order the scan, order the right scan, and tell them what to look for. Now, pupil is important because the pupillomotor fibers coat the third nerve. They're superficial. So they're vulnerable to compression from an aneurysm in the subarachnoid space. And it's typically the posterior communicating artery because the vessel and the nerve run in parallel. Now, something touching from the outside will get those pupillomotor fibers and the third nerve as well, leading to a dilated pupil. But if there's a core infarction from hypertension, diabetes, or a combination of the two, or other arteriosclerotic disease, the third nerve is affected, but due to rich anastomotic watershed blood supply, the pupillomotor fibers are going to be spared. Now, you can have a third nerve palsy where the pupil is initially spared. There's about 7 or 10 cases reported in the literature from an aneurysm. You're not going to have an aneurysm cause compression and affect only the pupil. An isolated dilated pupil is not an aneurysm. Now, very important is how close together are the vessel and the nerves. If it's far apart anatomically, you need a very large aneurysm in order to reach it and cause compression. Caveat: if the nerve and the vessel are very, very close together, there can be a small aneurysm that causes compression, and it can be missed on imaging, and that's a very important consideration. So if you have a clinical suspicion that the patient is aneurysmal, even if the imaging comes back negative, pursue it. Greg and I have 2 friends and colleagues, Dr. Nancy Newman and Valerie Buse, who are neuro ophthalmologists out of Emory University, and Valerie tells a story of a patient, a woman she had seen, who had a pupil-involved third nerve palsy, and she kept insisting, this patient has an aneurysm. I don't need to see this patient. It needs to see neurosurgery. But the imaging came back normal, and she said, I don't care. They need to see neurosurgery. And she even got a repeat image that came back normal. And she went with the radiologist and looked at every aspect and every cut, and then they found it together. But she knew, based upon the clinical findings in the face of quote-unquote normal imaging, that the patient had an aneurysm. Patient was rushed to surgery, craniotomy, and as they opened up her skull, the aneurysm burst. Fortunately, she was in the OR, and they saved her. So some more clues. A pupil-involved third nerve palsy is a posterior communicating artery aneurysm until proven otherwise, and an incomplete or partial palsy is an aneurysm until proven otherwise, regardless of the pupil. Here we have a patient who's got a little bit of ptosis and a little bit of motility deficit. That is not good. That means there's probably a developing aneurysm that is just now beginning to grow. And why is this important? 30% of third nerve palsies are caused by aneurysm. Now, what I want to stress to you, you can't look at this fact in isolation and say, well, Joe said there's only a 30% chance that my third nerve palsy has it. And that's not true. There are patients based upon clinical features that you can look and say there's a 90% chance that this is an aneurysm. In other patients, you can look and say there's a 5% chance. I'm just saying about 30% are caused by aneurysms. Pain is pain. It's not diagnostic and helpful only when it's present. It's only helpful if it's not present. Aneurysms are virtually always painful. Ischemic vascular palsy are painful 90% of the time. Pain is only helpful when it's not there. We can't qualify the pain. We can't think that an aneurysm is going to be a boring, debilitating, thunderclap, hemicranial pain. You can't qualify it. Case in point, Temple University football player develops a third nerve palsy with a little bit of headache, aneurysm. Little old lady, third nerve palsy, worst headache of her life, diabetes. Pain is only helpful when it's not there. Aneurysms are always painful. Ischemic palsy are painful 90% of the time. Vasculopathic thirds will resolve in time, usually within 6 to 12 weeks. They're certainly better within about 6 weeks. But aneurysms will rupture over time. Now, why is this important? If it's caused by an aneurysm, 20% of patients will die within 48 hours from rupture. It ruptures. There's only so much space in the cranial vault. Blood will fill the cranial vault, causes the brainstem to herniate down through foramen magnum, causes respiratory collapse and death. 20%, if it's aneurysmal, 20% will die within 40 hours from rupture of the aneurysm. Overall, half these people die. It's got a 50% mortality rate. The average time from onset to rupture is within about a month. 80% will rupture within that time. Many will not make it to the hospital. That's why it's not unwise to call an ambulance. Now, how are these treated? Well, there are two ways to treat it. One is with catheterization, where they'll go through the femoral artery, or maybe even with a skilled interventional radiologist through the radial muscle in the wrist. They'll snake a catheter up here. If necessary, they'll put a stent in this vessel and then squeeze these inert coils like squeezing toothpaste in there that will pack it in. So the stent keeps the vessel open. The toothpaste and the coils keep blood from getting in and prevent rupture. The other approach is with craniotomy. They actually open the skull and we'll use an aneurysm clipping it like a clothespin on a bag of potato chips, or a clip on a bag. I don't think anyone uses clothespins any longer, but like a clip like in a bag of potato chips. Both are effective. Both are easy procedures for a skilled neurosurgeon. Both have good outcomes. Aneurysm clips tend to have a little better recovery of function, but they're still very successful. The only difference is aneurysm clip involves a craniotomy and an open skull. This doesn't. Here's a rule that's violated every training program, optometry and ophthalmology across the country every year. Never dilate a patient with a third nerve palsy. Why? Somebody downstream is going to have to look at that pupil. And if they don't see that pupil, they're not going to be happy with you. Don't dilate. Look with your undilated 90, use your Optos, use your Claris, use your undilated camera, take a quick picture. Don't dilate. You don't need it. We talked about this. ruptured aneurysms, about got a 5% surgical mortality, and they're going to be functionally impaired neurologically afterwards. Unruptured aneurysms, generally no mortality, so they can have some pretty good outcomes. Now, rules for imaging third nerve palsies. Digital subtraction angiography is the gold standard, but CT and CT angiography is really the preferred non-invasive imaging for third nerve palsy. CT will identify subarachnoid hemorrhage, and CTA will actually reconstruct the vascular system where the aneurysm can be seen. Now, CTA does require contrast. They're renally impaired, they need MRI. If they're claustrophobic or they have a pacemaker like my patient did, they have to have a CT, not an MRI. MRI is a little better if it's not an aneurysm, maybe it's some sort of compressive lesion. And MRI really adds a little time to a scan. Today, patients with third nerve palsy will get imaged. Most people in neuro ophthalmic disease neurology all agree. And they'll probably get a CT, CTA, followed by an MR, MRA. And these are, pretty good representations of how the CTA can actually put it together. If you're ever going to order this, always spend the extra money and get the ones that come with the arrows because it's easier to interpret. Different patient, different prognosis. 63-year-old female, diabetic and hypertensive, has a sudden onset retroorbital pain. She has a complete ptosis. And she's not complaining about ptosis or double vision. She's complaining about the pain. She cannot look up. She cannot look down. She cannot adduct. She's down and out. She can abduct. She's got complete third nerve palsy with pupil sparing. She's older. Vasculopathic risk factors. So which is better, one or two? She resolved over several weeks without complication. He was hospitalized 23 days, 2 neurosurgical interventions, but he did live. Always suspect the worst. An optometrist just saw a patient with a third nerve palsy. I was talking about this out west one time, somewhere in Montana maybe, I don't recall, or Wyoming. And somebody very bravely got up during the talk and shared a case. And he said how they saw a patient with third nerve palsy in their practice. It was very, very rural. They referred the patient to an ophthalmologist the next day, but the patient was aneurysmal. They had a subarachnoid hemorrhage and died overnight. Never saw the ophthalmologist. So always suspect the worst. Now, does the presence or vasculopathic risk factors help? Well, arterial sclerosis, microvascular disease, it's all very common in an elderly person, but it doesn't rule out an aneurysm. So the answer is no, but it makes me very nervous when it's not there. Does the acuteness of presentation help? Well, yes and no. Aneurysmal expansion is usually pretty acute, but chronic and evolving cases are pretty well known. So, acute cases are worrisome. Excuse me. Chronic and improving is less worrisome, but doesn't rule out an aneurysm. Resolved, not recur, that's the best. So what is our assessment here? What is our threat assessment of an isolated third nerve palsy? What is the risk of aneurysm? An isolated dilated pupil is trauma. It's a ganglionic issue. It's a pharmacologic misadventure. It is not an aneurysm. A complete third nerve palsy with a normal pupil is a low risk of aneurysm, but they will get neuroimaged. A partial third nerve palsy with a normal pupil is a high risk. And a pupil involved third is an emergency. We talked about this, and I can say we're never out of the woods. Patient developed a third nerve palsy from an aneurysm, was successfully treated with an aneurysm clip. All those coils I told you, they're inert, but not at one time, not all those clips were MRI approved. A radiologic tech didn't verify what type of clip was used. Underwent a follow-up MRI in a major medical center with a non-approved clip. It displaced during the MRI. Patient had a fatal hemorrhage during the procedure, died in the tube. Survived the disease, killed by the follow-up. Greg, let's hit let's start sticking our landing. We hit our last polling question, and I'll hit my last slide, and I think we'll start wrapping it up.
Okay, the polling question is launched, and it says, which of the following doesn't need to be sent to the hospital emergency room? And Joe, you have optic atrophy and vision loss of 3 months duration, pupil involved cranial nerve 3 palsy, pupil sparing partial third nerve palsy, sudden onset painful Horner's syndrome. Give them a few seconds. And for those who that are want the handout, I just under files launched the handout probably about a minute ago. You can go and download this, the handout.
And there are a few cases that we did not get to, so don't worry about that. We'll come back in the future. Yes, Greg?
Yeah, so I was just going to give you the results.
Okay.
Majority, 86%, are saying that of which of the following doesn't need to go to the hospital emergency room. They're saying optic atrophy and vision loss of 3 months duration.
Yes, because how long do we have to figure that out?
3 months.
3 months. Well, I'm going to wrap up because there's a lot of stuff in that last section. If you can't remember that, just remember my ode to a third nerve. When the eye is down and out with ptosis, you better hope for meiosis. If the palsy is total with pupil sparing, and an oldie is vascular and not too daring. A partial palsy calls for double duty because it's probably an aneurysm going through puberty. But if the pupil is dilated and aneurysm has violated, no time for deferral and no time for referral, send to the ER without debate. Remember, 20% will die within the first 48. If you can remember that, you've got everything you need for third nerve. Greg, I think it's time for us to land this flight and disembark, everybody. I'm happy everybody joined. Hopefully this was a not too painful 3 hours and a good way to get some education. We will be doing future webinars, probably about 2 a month, and we're going to be putting them on our website and sending out e-blasts as we put them together. In the special COVID time when meetings are being canceled, I think this is certainly a viable option, and we know you have some options, so we do thank you for joining OEC tonight. Greg?
Yes, I'll echo the thank you, but we do have a question that is here. It says, will someone with a history of a blepharoplasty mask a partial ptosis? And for an example, can it be difficult to assess the ptosis?
The answer is yes. And if you go back to that older man who was diabetic, he had so much dermal chalasis, it was hard to assess. The key is the patient should be able to tell you there's something different. That you might not notice it as well, but they should notice it. Great question. Anything else, Greg?
Nope. We've had just some people saying thank you, very helpful. I know I appreciate the odes and that I hear them in my head when I'm in clinic, and so it's kind of nice. I will echo a few. You mentioned working with some of the neuro ophthalmologists, and I'm glad that there was a lot of people on here tonight taking this course for the fact that the neuro ophthalmologists love teaching optometry because they know that there's a shortage. And we always want to refer to retina and somewhere else. And they're just like, listen, Joe said it, we all take great histories. Optometry are great history takers. And we spend time and we talk to our patients. And the neuro-ophthalmologists are really trying to spend a lot of time training the optometrists. And because they really want us to be able to handle it and get these images and take care of these patients. They really don't need a referral, as Joe pointed out, because of the urgency of some of these cases. So great to have you doing this, Joe, and help them spread that word to our colleagues, because we certainly can't handle this and getting these patients to the right place. So I was going to just, and Joe, I'll let you wrap it up. Just let me remind everyone that Vanessa, our conference coordinator, will send, if you sent your OE tracker, they will get uploaded this week, and it's going to take about a week after that because Arbo is so busy with uploading numbers. And we will also send you a letter of certificate of attendance, the email that you used to register for this tonight. So Give us about a week to do that. We just did another opioid lecture last night. So, Joe, that's my final comments. I'll let you kind of land this Delta plane.
Well, thank you for everybody. I see some old friends in there. Al, hi. Mitchell, hi. Austin, good to see you. Hope everybody's doing well. Laura, thank you. Good to see everybody, and be safe. And hopefully someday, in the not too distant future, we'll be able to look at each other eye to eye, and I can call on people instead of just Greg. All right, guys, have a good night, and thanks a lot.
Bye-bye now.